Okay, now let's talk about the clinical features. So whenever we talk about clinical features, so there is an acute illness and there's a late sequelae. Okay, so acute illness, there is two primary forms. Okay, so one is an acute febrile illness and other one is the neurological illness. The late sequelae is rheumatic heart disease and Jacquard arthropathy. Now you might be thinking, what is this Jacquard arthropathy? Remember, the Jacquard arthropathy is the deformities of the joint which is associated with systemic lupus erythematosus as well as it's associated with rheumatic fever. Okay, so Jacquard arthropathy is simply a joint deformity. Okay, it's a deformity which is present in the joints. Okay, Jacquard arthropathy. So acute febrile illness and neurological illness. So neurological illness is basically synonym chorea. Okay, so in acute illness you'll see all the features that is seen in actual disease, like it's 2 to 4 weeks of inset after the group A streptococcus. Its fever will be seen, joint symptoms will be seen, okay, and signs. Carditis will be the clinical and subclinical. It's basically carditis. Skin manifestation, subcutaneous nodules are very rare. Raised in the inflammatory markers like ESR and CRP. Evidence of preceding GAS infection, elevated ASO and anti-DNase. This is very important. Please write it down. ASO and anti-DNase are the ones that we tend to take under consideration whenever we suspect a case of rheumatic heart disease. Okay, so any person who comes to the Department of Medicine for an evaluation of rheumatic heart disease, it's better to go for an ASO and anti-DNase and ASO, and do ask history of scarlet fever and also do ask history of certain crust or certain lesions in the skin. Okay, 4 weeks prior. Okay, so what's the beauty of undergoing anti-streptococcal O antigen? Okay, it's known as anti-streptococcal O toxin. Okay, it's anti-streptococcal O toxin. So we are looking for these toxins, whether or not that it's present or not. Okay, and dramatic symptom response to aspirin and NSAIDs, right? And we all know the treatment for the joint manifestation, the arthritis secondary to rheumatic heart disease, is rheumatic fever. It's aspirin and NSAIDs, right? So it tends to relieve with aspirin and NSAIDs, joint pain. Duration is less than 6 weeks and followed by rheumatic heart disease in approximately 75% of the patient. But neurological manifestation, remember the synonym chorea, it's highly associated with subcutaneous nodules as well as erythema multiformis. Now this erythema multiformis, it's not seen in the face. Okay, the face is spared in the case of erythema multiformis. So you will not see anything in the face, but you will appreciate nodules in the extensor aspect. Okay, and there will be behavioral disorders. Okay, and this ASO and anti-DNase may be helpful in the case of chronic cases, but ASO is an acute phase reaction. So ASO is of no role in the case of chronic disease. So it's followed by rheumatic heart disease in the approximately 50% of the patient. Okay, so moreover, whenever we have neurological manifestation, the prognosis becomes bad. Okay, the prognosis is bad because neurological manifestation with synonym chorea, they have particularly 2-3 signs positive, milkmaid signs, and there's also spooning of the hands, which is known, there's spooning of the hands, right? Deformed handwriting. Okay, deformed handwriting. Now patient may report prior sore throat, but often the infection may be subclinical. So there is polyarthritis, carditis, chorea, erythema marginatum, and subcutaneous nodules. Now joint involvement. So let's talk about each and every manifestation in brief detail. This is very important. Okay, it's so important, I can say. Let's talk about it. So the joint involvement is a migratory joint involvement. Okay, so typically migratory joint involvement. Arthralgia without arthritis is also relatively common. So there is pain, but there is no arthritis. Okay, so there is pain, there is arthralgia. Arthralgia means pain. Okay, arthralgia is there, but there is without arthritis. It's also relatively common. Okay, aseptic monoarthritis may be presenting feature. Almost always affects large joints, that's the knee, ankle, hip, elbow, wrist. So any patient who presents with rheumatic fever, you should also rule out disease like juvenile idiopathic arthritis. The juvenile idiopathic arthritis can also affect the large joints, and also it might be associated with other features. Okay, so I'll take some time, 1-2 minutes time, to take you to SOGIA. SOGIA is systemic onset juvenile idiopathic arthritis. As the word says, it is associated with the juvenile age group. Okay, and if it's a juvenile age group, what's the most important thing you should understand? So it's a juvenile age group. What are you going to understand in the case of juvenile age group? Yes, we are going to understand that it has, so I've made a mnemonics for you. So PEM has Kwashiorkor. So protein energy modulation has Kwashiorkor. So P stands for pericarditis, pleuritis. Okay. E stands for evanescent rash. M stands for H stands for hepatosplenomegaly. HAS, no, this hepatosplenomegaly. K stands for Kogn's phenomena. So along the line of trauma, there is similar appearing lesion, which is known as Kogn's phenomena. Kogn's phenomena is actually seen in the case of lichen planus and psoriasis, but pseudokogners, it's seen in the case of molluscum contagiosum, and it's seen in the case of warts. Okay, now the joints is typically involved. There is a migratory joint involvement. There's a migratory joint involvement. Okay, migratory joint involvement, and there can be arthralgia without arthritis. Almost affects large joints. Pain, usually severe and disabling until anti-inflammatory medication is commenced. Highly responds to salicylates, NSAIDs if persists for more than 48 hours after starting salicylate. Reconsider diagnosis of ERF. Okay, so usually the joint pain, it works really good with the salicylic acid. Okay, so joint pain, it's relatively I would say it's very much tolerated with salicylic acid, the joint pain. Okay, the cardiac involvement. So endomyocardium and pericardium may be involved. It can lead to pancreatitis. Valvular damage is the hallmark. Mitral valve is almost always affected, leading to mitral regurgitation. Remember, acute case is associated with regurgitation. Okay, G-U-G-U, regurgitation. But chronic is stenotic. It's rhyming, no? Chronic is stenotic. I studied this from one of our YouTube channel expert. One is known as Medicosis Perfectionalist. Very good videos. So he says this: acute is for regurgitation, chronic is for stenosis. Okay. Now the second most commonly involved is the aortic. The aortic is the second most commonly involved. The pulmonary tricuspid. The pulmonary tricuspid, usually secondary to increased pulmonary pressure from left side valvular disease. Okay. Now early valvular damage. So what do you mean by early valvular damage? So early valvular damage, it leads to regurgitation, presence of valvulitis, established by auscultative finding and echocardiographic evidence of mitral or aortic regurgitation. So in the case of mitral regurgitation, I would expect there to be a holosystolic murmur with an evidence of increase in the pressure of the left atrium with left atrial enlargement. Okay. So if there is left atrial enlargement, there can sometimes be, okay, left atrial pressure might increase to pump the excess amount of blood. Now again, the left ventricle pressure also increases to accommodate more amount of blood which is present in the next diastole. But here the dilatation is an eccentric dilatation as compared to concentric dilatation, which is seen in the case of aortic stenosis. Okay. So over ensuing years, the leaflet thickening, scarring and calcification leads to stenosis. Yes, we told, right? Chronic is a stenotic, but early it's a regurgitation. Okay. So any stenotic lesion, you can say that the chronic rheumatic heart disease can lead to a stenotic lesion. Second to leaflet thickening, scarring and calcification, right? Myocardial inflammation may affect electrical conduction pathways, and that can lead to PR prolongation, softening of the S1. So why softening of the S1? So in the case of stenosis, there is loud or attenuated S1. But in the case of regurgitation, there is soft S1. And why there is PR elongation? Of course, atrial contraction, and then the mechanism of flow of blood is abnormal or disturbed, that leads to PR prolongation. Up to 60% of the patients with acute rheumatic fever eventually develop rheumatic heart disease, often asymptomatic until the disease progresses to cardiac failure. So of course it can lead to cardiac failure if not intervened on time. Okay. Joint involvement, migratory joint involvement, larger joint involvement, better with NSAIDs. Consider different diagnosis if not relieved within 48 hours. Okay. And remember, 75% of the patient will present with arthritis. Okay. So let's take one moment to look into the slide. Okay. Okay, great. Thank you. So let's look into the syndrome chorea. So irregular disorders characterized by chorea, involuntary, brief, random and irregular movements of limb and face, emotional lability and hypotonia, prolonged latent period 1 to 8 months, commonly in absence of other manifestation. So basically this movement, the syndrome chorea movement, what we need to say is syndrome chorea movement is involuntary movement. It is a involuntary movement and it is brief. Brief means for some period of time, and it is random. It is random and it is irregular. It is irregular. Okay. It is brief, it is random and it is irregular, and it's very rapid. It's very rapid. Okay. Irregular movement is seen with regards to your limbs and face. Okay, limbs and face irregular movement, and there is hypotonia. Okay. Okay, so it's more commonly seen with females. Okay, more commonly seen with females, and typical onset may be insidious, may be abrupt. Okay, recurrence not uncommon, so there can be recurrence, but it's reversible condition. It's a reversible condition. Most recover fully within 6 weeks, and nearly all within 6 months. Okay, so someone who is suffering from syndrome chorea's patient will recover, write it down, recover in 6 weeks. Okay, may take 6 months for complete recovery. Okay, so we'll be continuing from slide 18 in the next